This is chapter 8 in Karsh, which just goes over anti-infective agents in general. Um, this goes with the infection module in NSG 152. The development of anti-infective therapy really began in the 1920s with Paul Ehrlich, who started developing synthetic chemicals that were effective against infection causing cells. We also saw the discovery of penicillin from a mold sample. In 1935, the sulfonamides were introduced, and you can kind of see from the picture that is on here. Actually, this is from a pharmaceutical company that actually was based here in Bristol, Tennessee, and Virginia. And sulfonamides, were seen as being like the greatest thing that was out there, but actually there were quite a few problems with that related to the way that the medication was suspended and what it was suspended in, and so there was a lot of strides that needed to take place in anti-infective therapy. The therapeutic action of anti-infectives in general include they interfere with the biosynthesis of the bacterial cell wall. They prevent the cells from the invading organism from using substances that are essential to their growth and development. So it interferes with their actual, process of growing and developing and maturing. Uh, and anti-infectives also interfere with the steps involved in protein synthesis, as well as interfering with DNA synthesis of the cells, and they can alter the permeability of the cell membrane to allow essential cellular components to leak out. So, in general, these are all the different ways that anti-infectives can work, and so they may do multiple of these, or they may do one of these, but with all of these, with the same process of thinking about that they need to um, prevent the infection or the infectious organism from being able to grow, to mature, develop, and move around the body. Drug therapy across the lifespan. So, this is just a little focus box that is in your pharmacology textbook that just focuses on general principles of how we use infectives across the lifespan. So, for example, you see with children here, we want to use anti-infectives with caution because we don't want to expose children to more anti-infectives than they really need. A lot of parents have really pushed the use of antibiotics in particular, even when they're not known to help the particular infection that the child has. One particular controversy, and that's mentioned here, is ear infections, which is a fairly common problem. It actually is one of our exemplars for this module, and it's not necessarily going to be the best treatment in terms of using antibiotics. There's kind of some controversy. Some folks who weigh in on that definitely we should be using them, and then folks who are weighing in that we should not be using those as a general rule. Definitely should not be using antibiotics or antibacterials with viral infections. They're not going to help. And so that's where patient education should come in. With adult patients, we see parents as well as adults getting care for themselves, demanding anti-infectives because they need the quick cure. Just give me a shot of Rocephin, give me a shot of some type of antibacterial so I can get back to work quicker and do what I need to do. The other caution with adults is with pregnant women or women who are lactating and nursing a child. that we need to be very cautious about what is used, because many of the anti-infectives can cross um, into the breast milk and cause problems with the neonate. Also with pregnant women, could cause problems with the fetus. In older adults, the issue is that infections present in an atypical fashion. So we don't see the exact same signs and symptoms that we would see in younger people and younger adults. So with an older adult, it's going to be more important to do culture and sensitivity tests to make sure that we know the type of infection that we're dealing with, as well as what specific medication would be responsive, that the infection would be responsive to. Also, your older adult is going to be at higher risk for more adverse reactions, including GI, renal, and neurological effects. Also, we need to follow them much more closely for their nutrition and their hydration when they're taking medication therapy as it relates to adverse effects and side effects. Because like in your older adult, they very well are not going to have the liver and the kidney function to be able to metabolize and excrete medications in the same way that other adults and younger folks are. So with anti-infective therapy, um, you know, they're going to vary their effectiveness against invading organisms. Some are selective. They're only going to be effective for a very few microorganisms, very specific. Some of your anti-infectives are going to actually be bactericidal, where they actually kill the organism or kill the cell. Some are bacteriostatic and they prevent the reproduction. So they're going to keep them from multiplying and from creating more, but they're not going to get rid of all of the organism. All right, so narrow spectrum versus broad spectrum. So when we look at the different types of anti-infectives, we see that some of them are going to be what we call narrow spectrum. They are effective against only a few microorganisms with a very specific pathway, or they affect a very specific enzyme. Others, in which these are used more widespread, are broad spectrum. So broad spectrum or extended spectrum, as they're called sometimes, are going to treat a variety of organisms. But your broad spectrum versus your narrow spectrum, your broad spectrum anti-infectives are going to be more likely to disrupt what we call normal flora. So the good bacteria that we find in our body that actually does help to keep our intestines and our reproductive tract, all of that from head to toe, to keep that functioning as it's supposed to. We have to have some of that good flora in there. What broad spectrum anti-infectives will do, they will actually disrupt that normal flora, and they may end up causing what we call a supra infection. Narrow spectrum are going to be less likely to do that. So when you're looking at therapeutic action of anti-infective, so this is like a sample box here showing a mechanism of action for one of the antibiotics in this chapter. So this is for bacitracin, which we see here as an antibiotic that interferes with the cell wall synthesis of susceptible staph bacteria. And you can see they've listed two specific adverse effects, one of nephrotoxicity and one of a super infection. So nephrotoxicity being it's going to be toxic to the kidneys, and the super infection, that's what we were just speaking of in the previous slide, where it's going to wipe out normal flora and can cause, for example, a super infection could be something along the lines of thrush, like in the mouth, or it could be like a yeast infection, like in the vaginal tract. And this is a medication that we use. With infants here, like eye infections, minor minor skin wounds, sorry, that in treatment of skin infections that are related to staph right here. Intramuscular, ophthalmic, or it's topical. So you see here it's listed interferes with the cell wall synthesis. So that's an example of how an antibiotic, its therapeutic action is displayed. All right, so human immune response. So looking at the goal of anti-infective therapy is the reduction of the population of the invading organism. In some cases, we're going to try to, that antibiotic is going to be able to kill that microorganism. In other cases, it's going to just prevent its reproduction. We have drugs that will eliminate all traces of that invading pathogen. The problem with those types of medications is that they could be toxic as well, so causing toxic problems, for example, to the ears, the kidneys, are a couple of examples. Immune response is, that very complex process of the body that involves all of those chemical mediators, white blood cells, antibodies, enzymes, and chemicals, and how the body is going to respond, one, in a kind of a natural way based on the immune system that we have, and then be helped by that anti-infective therapy, hopefully, to work together to reduce that population of the invading organism. But, we hope to pick medications and give to patients that are not going to be as toxic to the host if we can help that. So we see like a couple of different types of resistance take place: natural or acquired resistance. So the ability over time to adapt to an anti-infective drug and produce cells that are no longer affected by that particular drug. So there can be some natural resistance where our body already has a resistance to certain anti-infectives. What we see more of is the acquired resistance, and our next slide we'll talk about that just a little bit more. But where it has developed over time, and often because we have used antibiotics, incorrectly, or we have used them too often. Anti-infectives act on specific enzyme systems or biological processes. Many microorganisms that do not act on this system are not affected by this particular drug. So some anti-infectives, are not going to be useful to certain microorganisms because of the way of what their therapeutic action is of those anti-infectives. So if a patient is getting prescribed a medication and it is not effective on the particular way that that microorganism actually works and functions and reproduces, it doesn't matter how much of that antibiotic that we take, it is not going to affect that microorganism, and our body will actually acquire a resistance. So when we do really need that antibiotic, is not going to be effective. So just a little bit here about acquired resistance. So microorganisms that were once sensitive to this particular drug have begun to develop an acquired resistance. And so as a result, we see serious clinical problems. So when we think about antimicrobial resistance, the microbe becomes resistant to that drug. So for example, the beta-lactam antibiotics are affected by the microbe's ability to produce beta-lactamase enzymes, which can inactivate the particular drug. So many microorganisms have developed these enzymes to inactivate the effects of penicillin. Staph aureus is almost entirely penicillin resistant. So you have MRSA, which is methicillin resistant Staphylococcus aureus. And so that pathogen is widely resistant to almost all of the different types of penicillins. So there's an alteration of the penicillin binding proteins, which reduces the ability of the penicillins to inhibit the wall synthesis. Okay, so what does that mean? It means that MRSA has resisted, or it's become it's acquired a resistance to all the different types of penicillins over time, so that the penicillin's therapeutic action of inhibiting cell wall synthesis is no longer effective on that strain of bacteria. Also, there are many strains of MRSA that are also resistant to other medications like the aminoglycosides and tetracyclines as well. You also have some of your other drug resistant bacteria like vancomycin resistant enterococcus, or VRE. And they have also developed resistance to some of the different types of antibiotics like penicillins, gentamicin, which is an aminoglycoside, and vancomycin. Even some other antibiotics, uh, you know, that have been used in their place are starting to become resistant, like Cipro. TB has also become a multi-drug resistant organism. So what this means is we do not have adequate drug therapy to treat those resistant microorganisms. And some of that could be that the wrong medication was prescribed, or it was taken for too short a time, or in too low a dose, or a patient that was not compliant with the course of the therapy. Ways that anti-infective agent resistance develops: they produce an enzyme that deactivates the antimicrobial, or they change cell permeability that prevents the drug from being able to enter. They alter their transport systems to exclude the drug from being actively transported into the cell. They alter binding sites on the membranes or ribosomes, which then no longer will accept the drugs, or they produce a chemical that acts as an antagonist to the drugs. So let's look at a question. Which of the following has been found to be as important as drug therapy when treating infections in folks who are immune suppressed, so where they have a depressed immune system? A, maintaining standard precautions. B, proper nutrition. C, good hand washing. Or D, exercise. So give that some thought, and on the next slide we'll take a look at the answer. And so the answer to our question is proper nutrition. And the rationale for that, in helping folks who are immunosuppressed cope with infections, prevention of infection, and proper nutrition are often as important as drug therapy, because it's going to help them have the best possible immune system that they can possibly have. So how do we prevent resistance? Well, one, antimicrobial agents should be limited to the treatment of specific pathogens that are sensitive to the drug that is being used or being prescribed. We want to make sure that high enough doses are being used and the duration of the drug therapy is long enough. Now, what happens is our patients get prescribed a medication, and they're like, oh, a couple of days into taking that antimicrobial, they're feeling so much better. I'm just going to quit taking this. I'm going to put it up in my medicine cabinet, and I am going to save it for the next time that I'm sick. So instead of taking it for 5 days or 7 days or 10 days, whatever was prescribed for that particular infection and antimicrobial, they have shortened the amount of time, they've shortened the duration, and that's going to help cause increased resistance. We also want to make sure that we're being very cautious about indiscriminate use of anti-infectives, that we're that the providers that we're working with, and that our patients understand that we're not going to give them anti-infectives for everything that they come in for, and that that is not appropriate for things like viruses. It's not appropriate for certain um, you know disorders, that would not necessarily be the treatment that is going to be recommended. And so that's where patient teaching would be appropriate. Factors affecting prescribing anti-infective agents. So first, the anti-infective agent needs to be correctly identified. So that may be done through a culture. It might be done through gram staining and looking at them underneath a microscope. Next then would be the selection of the right drug. And so the most important thing is that the right drug is one that's going to cause the least complications for that patient. That's going to increase the possibility that they are going to continue taking the medication for the duration of the therapy. And we want the one that is the most effective against the pathogen that's involved, so that we see, here's what the pathogen is, here's what medications that pathogen is going to be sensitive to and be affected by, and then those are the medications that the prescriber would then choose from. Problems with treating infections in immunosuppressed patients. Um, Anti-infective drugs cannot totally eliminate the pathogen without causing severe toxicity in the host. So that's a problem for these particular patients. The other issue is that these patients do not have the immune system response in place to be able to deal, even if there's just a very few um, organisms. So sometimes you'll see these are the patients in the hospital that will put on additional precautions to try to prevent microorganisms from coming in contact with them. These would be the patients who are under like neutropenic precautions, where they are not going to be able to have, say, like fresh fruit in their room or fresh flowers, because we don't want any possible sources of microorganisms coming in contact with them. So when we identify a pathogen, it's done by culture. We mentioned that. So we're going to culture a tissue sample of the infected tissue. It's going to grow on an agar plate. We may even use like these staining techniques and microscopic examination to actually look at that bacteria. And you have a couple pictures down here below where um, where you've got gram-positive bacteria, and so it's stained in a particular way. So under a microscope, we would take a look at that, and so it would show up in a certain color, versus gram-negative would show up in a different color, related to how the cell membrane and the outer membranes react to the staining techniques. Also, the stool can be examined for ova or eggs and parasites that might help us identify the pathogens that we were dealing with. So sensitivity of a pathogen. So sensitivity is going to show which drugs are capable of controlling the particular microorganism that we have just grown by culture. It's important, particularly with microorganisms that we know to be resistant, like MRSA, Staphylococcus aureus, Enterococcus, for example. Along with a culture, it's going to, part of that culture, it's going to identify the pathogen, and then the sensitivity piece of that will help us to select the appropriate drug for treatment. Sometimes we're going to do combination therapy, so we're drugs are going to be combined with smaller dosages of each drugs. Where they're going to have a synergistic effect, that they actually are going to work better because they are combined together than if we gave them separately. And in infections caused by more than one organism, each pathogen may react in a different way, or to react better to a different anti-infective agent. So then we may the combined effects can delay the emergence of resistant strains. So sometimes it's better to have those smaller doses together in a medication than it would be to give an entire course of one medication and then give a entire course of another medication separately. Prophylaxis of anti-infective agents. So sometimes we're going to give anti-infective agents not because there is already an active infection in place, but because we want to prevent an infection from taking place. So, for example, folks who are traveling to an area where malaria is endemic, and we learned about endemic in this module, where malaria is always present, then we would use that. If I was going to travel to an area like Africa, then I would take, a prophylaxis doses of antimalarial medications. Patients who are going to undergo GI or genitourinary surgery would get preventative anti-infective therapy. Patients that have known cardiac valve disease or have had valve replacements or other conditions where they have had invasive procedures may undergo preventative therapies. Adverse reactions to anti-infective. So again, remember in this presentation, we are really just looking at in general. So, not really talking about, a specific drug, but pretty much if we're talking about anti-infective therapies in general, these are some of the adverse effects that we see most often. We see folks with kidney damage related to anti-infectives, GI tract toxicity, neurotoxicity, where it is actually toxic to the nerves, hypersensitivity reactions, where they have like allergic reactions to medications, and those super infections where we've wiped out the normal flora, and then that's allowed opportunistic infections to take place, like yeast infections, thrush in the mouth, or candida, as that's also called, or like a vaginal yeast infection is another example. So here's another question for you. You're caring for a patient who has just been diagnosed with a Pseudomonas infection. You know that in deciding what medication to order for this patient, the physician will take what into account. Okay, so here are your choices. A, the patient's age, the patient's gender, the drug that causes the least complication, or the drug that has the longest half-life. Okay. So, um, so there are some of these that, I might would consider the patient's age, but is that something that I'm going to consider every time? No. So this is a question where we want to know in general, which of these things would I always want to take into consideration? And that being the case, it is not A. Um, I might sometimes take gender into consideration, but usually not. So we've narrowed it down between C and D. Okay, so the longest half-life, that's one that's going to stay in the body longer. So the longer a drug is in the body, then the more possibilities to create problems. So that brings us to which has to be C. So when we identify the correct pathogen and we select the right drug, we want the one that causes the least complications for that particular patient. Now, if I have a child as a patient, I'm going to take this into consideration, but I would have to take their age into consideration. Maybe not so much for what the right drug is to give them as much as what the right dose would be for them.